Angina pectoris, which is Latin for angere, which means to choke, and pectus means chest. So it is to choke the chest. Pathogenesis of angina pectoris. There is atherosclerosis of coronary arteries leading to chronic plaque buildup in coronary arteries. This narrows the lumen, reducing blood flow, especially problematic during increased oxygen demand. Imbalance between oxygen supply and demand. The heart needs more oxygen during exertion, but narrowed vessels can't supply. This mismatch leads to myocardial ischemia. Okay, so there are three main types of angina. Number one is stable angina, which is triggered by exertion. Then there is unstable angina, which occurs even at rest. And then there is variant angina that is caused by coronary spasms. So clinical features. There will be substernal chest pain of 5 to 15 minutes duration relieved by rest or nitrates, aggravated by physical exertion, heavy meals, cold exposure, and intense emotion. Pain may radiate to jaw, neck, or arm. Pain may be associated with nausea, vomiting, sweating, or lightheadedness. So investigations, first of all, clinical consultation, history and examination. Then there is blood tests and 12-lead ECG. Consider chest X-ray and echo also. 12-lead ECG will show ST depression and T wave inversion, but it is usually normal in patients with stable angina. Then there is exercise ECG, which is also known as ETT. So exercise ECG, a patient with positive stress test should undergo cardiac catheterization. It is sensitive if the patient is able to increase heart rate to 85%. Signs of MI on ECG are planar ST depression, which indicates ischemia, downsloping ST depression, which also indicates ischemia, upsloping ST depression, which is normal. Coronary angiography. It is a test used to detect the anatomic location of coronary artery disease. Most accurate test for detecting coronary artery disease. It provides information as to which test is preferable, coronary artery bypass graft or percutaneous coronary intervention. Coming towards management, first of all, there is lifestyle modification. There is smoking cessation, weight reduction, reduce intake of saturated fats and cholesterols, control BP, treat hyperlipidemia. Medical management includes antiplatelet therapy, which is aspirin. It should be given to all patients with CAD, low dose uh, aspirin. Then there is clopidogrel, equally effective as aspirin. Then there is anti-anginal therapy, which includes nitrates, beta blockers, calcium channel blockers, potassium channel activators, and funny IF channel antagonists. First of all, there is nitrates, which include the drug glyceryl trinitrate. They cause venous and arteriolar dilatation. They decrease both preload and afterload, and their side effects are headache and orthostatic hypotension. Then there is beta blockers. They block sympathetic stimulation, lowering myocardial oxygen demand. Cardioselective beta blockers are better tolerated than non-selective. Cardioselective includes metoprolol and non-selective includes propranolol. Side effects of beta blockers are bronchospasm and withdrawal syndrome. That's why they are not given in asthmatic patients. Calcium channel blockers cause coronary vasodilatation and afterload reduction. There are two categories: dihydropyridine calcium channel blockers, which include nifedipine and nicardipine. They cause reflex tachycardia, therefore must be given with beta blockers. Second is non-dihydropyridine calcium channel blockers, which include verapamil and diltiazem, must not be given with beta blockers as it may result in profound bradycardia. Side effects of calcium channel blockers are myocardial depression, constipation, peripheral edema, flushing, headache, and dizziness. Potassium channel activators. Nicorandil is the only drug in this class. Like nitrates, these drugs cause venous and arteriolar dilatation. Then there is funny IF channel antagonist. Ivabradine is the first of this class, acts on the IF channel invert channel in the SA node, reducing the heart rate. Then there are some revascularization therapies. First of all, there is percutaneous coronary intervention or angiography, and then there is coronary artery bypass grafting. Thanks.